Hi everyone, welcome to Chapter 3 of Essentials of Human Diseases and Conditions. And today we're going to be talking about diseases of the immunological system. We're going to name the functional components of the immune system and characterize the three major functions. We'll list examples of inappropriate responses of the immune system and explain the difference between natural and artificial immunity. We'll also trace the formation of T and B cells from their stem cells and explain how they specifically protect the body against disease. We'll list 5 immunoglobulins and explain complement fixation. And we'll explain the ways in which HIV is transmitted. We'll list the guidelines for universal precautions in infection control, and we'll describe the primary absent or inadequate response of the immune system in the following diseases: common variable immunodeficiency, selective immunoglobulin A deficiency, and severe combined immunodeficiency, or SCIDs. We'll explain the destructive mechanisms in autoimmune disease and describe the symptoms and signs of pernicious anemia and the primary treatment, and describe the systemic features of systemic lupus erythematosus. We'll also recall the diagnostic criteria, and we'll detail the pathology of rheumatoid arthritis. We'll explain the primary objectives for the treatment of rheumatoid arthritis and compare the pathology of multiple sclerosis to myasthenia gravis. And we'll list the distinguishing diagnostic features of ankylosing spondylitis and describe the pathology of vasculitis. So, your immune system. I always start out each class with this question. What good is it? What does it do for you? Well, it keeps you free from disease, specifically the invasion of your body by pathogens. And what is a pathogen? A pathogen is any disease-causing entity. Pathogens can be living or non-living. Examples of living pathogens would be bacteria, mold, protozoans. Examples of non-living pathogens would be prions and viruses and toxins. So, what are the functional components of the immune system? The lymphoid tissue, primarily we're talking about the thymus and the bone marrow, and the secondary lymphoid tissue are the tonsils, the adenoids, the spleens, the Peyer's patches, and the appendix. The lymphocytes and the antibodies are tools used by specific immunity to fight pathogens, and we'll detail exactly how they work in a moment. And also macrophages, which are cells that wander throughout the body and gobble up pathogens that they see. Lymphoid tissue that we've detailed here is important for it to function properly. If your immune system is suppressed, the obvious outcome is that you'll be prone to opportunistic infections, which are infections that would not normally get a chance to produce disease, but in immunodeficient individuals, they can produce disease and even death. So what are macrophages and where are they found? They're phagocytic cells that are found in the blood, the liver, the brain, the lymph nodes, the spleen, and in other organs. And they wander around the body looking for pathogens, and they will consume them. They'll form a membrane-enclosed vesicle around the pathogen, take it inside the cell cytoplasm where it will fuse with the lysosome, and then fragments of that pathogen will be displayed on the cell surface as a method of alerting the immune system. The major functions of the immune system are to protect the body against foreign organisms, to maintain homeostasis by eliminating damaged cells, and this is again a role of phagocytosis, to battle infection. Immunocompetence is when the immune system reacts appropriately to an antigen and homeostasis is maintained. The immune system assists the body in protecting against invading organisms such as bacteria, viruses, fungi, and parasites. The initial immune reaction is where the body initially doesn't recognize the foreign agent and will fight to rid itself of that particular pathogen through a selection process in which we try to pick out the appropriate white blood cells that can best fight that particular disease-causing agent. What does it mean if the immune system is intact or immunocompetent? It means that the body can effectively react to an antigen and maintain homeostasis. So, let's take a little listen to the orderly functioning of the immune system.
Lymphatic vessels recycle excess tissue fluid that accumulates in the interstitium as a result of normal capillary leakage. The walls of the lymphatic vessels act as one-way valves, only letting fluid enter. Once in the vessels, the lymph is advanced toward the systemic circulation. Along the way, the lymph is filtered through several lymph nodes where it is inspected for foreign substances. Upon reaching the thoracic duct, the lymph re-enters circulation.
Activation of the immune response typically begins when a pathogen enters the body. Macrophages that encounter the pathogen ingest, process, and display the antigen fragments on their cell surfaces. Macrophages with antigen fragments displayed on their surfaces are called antigen-presenting cells. An antigen-presenting macrophage interacts with a T helper cell that can recognize the same antigen. During the interaction, the macrophage releases a chemical alarm signal called interleukin-1, which stimulates the T helper cell to secrete interleukin-2. Interleukin-2 causes the proliferation of certain cytotoxic T cells and B cells. The immune response from this point follows two paths, one using cytotoxic T cells and one using B cells. Normal cells of the body that become infected can also digest some of the pathogens and display antigen fragments on their cell surfaces. The body makes millions of different types of cytotoxic T cells. Each type is able to recognize a particular antigen. The cytotoxic T cells that are capable of recognizing the antigen displayed on the surfaces of infected cells bind to the infected cells and produce chemicals that kill the infected cell. Death of the infected cells results in destruction of the pathogen. B cells also come in millions of different types, each able to recognize a particular antigen. When B cells become activated by T helper cells, they differentiate into plasma cells. These plasma cells become antibody-producing factories, flooding the bloodstream with antibodies that can bind to the antigen involved in this infection. Antibodies bind to the antigens on the surfaces of the pathogens, marking them for destruction by macrophages. Some of the B cells do not turn into antibody factories, but instead become memory B cells that may survive for several decades. Because of these memory B cells, the secondary immune response to a future infection by the same pathogen is swifter and stronger. This powerful secondary immune response is what gives immunity to some diseases after you have had them once or after you have been vaccinated.
So, further discussion of the orderly functioning of the immune system. Let's look at some inappropriate responses. This is where the immune system can over-respond, under-respond, or react to your own tissues. Those are the three main classes. A hyperactive immune system is an allergic immune system. This is an excessive response to an antigen stimulation. An immunodeficient immune disorder, such as AIDS, is an inadequate response to pathogenic attack and sets us up for opportunistic infection. And an autoimmune disease is one where the immune system is directed against your own tissues, and you run the risk in that case of actually shutting down organs and causing systemic damage. Transplant rejection is an example of an immune attack in the event that in an incident where the procedure is actually beneficial to the patient. So what happens is, because there isn't the same set of molecules on the donor and the recipient tissue, the recipient will look at the graft as if it were a pathogen and attempt to destroy it. Each of these types of inappropriate immune system reactions emerges from a slightly different variation of the same immunologic processes that normally protect the body. Initially, The body's going to recognize an antigen or an immunogen as a foreign invader, and specific antibodies will be produced in response to this supposed attack. When the body can't distinguish between its own and foreign molecules, autoimmune disease, in which the immune system attacks its own tissues or organs, can result. The consequences of an organ transplant rejection are necrosis of the organ or transplant and the possibility of infection as well. If we look at some examples of types of immunity, they fall into four basic categories. There is natural active immunity, natural passive immunity, shown here and here. There's artificial active immunity, shown here, and artificial passive immunity, shown here. Immunity can be acquired by active or passive processes. Exposure to a disease such as measles will create a natural active immunity. A measles vaccination can also produce active immunity to the disease through artificial means. Passive immunity is acquired naturally through intrauterine development through the placenta or after birth through the breast milk. What is artificial passive immunity? Well, this is also known as prophylactic immunity, and it's provided to an individual through direct injection of antibodies from another host. So you might engage in artificial passive immunity if you were going, say, to a part of the world that was known to be infested with malaria, and you might get a shot of antibody against the malarial parasite. So let's keep in mind what each of these has as a consequence. In passive immunity, we only have transient protection because once the antibody has been flushed out of the system, we're now susceptible to the disease again. In active immunity, the immune system generates the antibody and it stays with your immune system your entire life in the form of memory cells. And as a result, if you encounter that pathogen anytime in the future, you're going to be able to more effectively fight it. Cellular elements of natural immunity include natural killer cells, polymorphonuclear neutrophils, macrophages. Cellular elements of acquired immunity include T lymphocytes, which are made in the thymus, and B lymphocytes, which are produced in bone marrow, as well as phagocytes. Innate immunity is a nonspecific attack on a foreign substance as soon as it's detected. It uses preformed activated components of the immune system. This response begins in a matter of hours or even less. Acquired immunity takes days or longer to be fully functional. It's a specific reaction to a unique antigen and only confers immunity to a pathogen that contains that antigen. Each time your body is exposed to the same antigen, the reaction becomes more efficient due to the cellular immune recognition of the foreign antigen's characteristics. How would you, for instance, characterize the reaction to a bee sting? And I'll give you a few moments here. Okay, and the answer that we're looking for is innate immunity. This is a diagram of B and T cell formation shown up here in a lineage chart. This would be the earliest form of the T or B cell, known as a stem cell. This will then differentiate into a lymphoid stem cell, which will then migrate to the bone marrow or to the thymus. They will form pre-B cells or prothrombocytes, respectively. The pre-B cells can then differentiate into B lymphocytoblasts or T lymphocytoblasts. The B lymphocytoblasts can then differentiate into B cells, which can then differentiate into either a plasma cell or, in response to an antigen, become an activated B cell, which can not only generate plasma cells but memory cells as well. The thymocyte in the thymus lineage pathway can differentiate into a T lymphocytoblast, which can then become a T cell, which upon contact with an antigen can become a sensitized T cell that can produce a memory or killer T, as well as a suppressor or helper T. And all these are extremely important in the proper functioning of the immune system, as we'll see. Both T and B cells have a common fetal origin, but their development continues in different tissues, T cells in the thymus versus B cells in the bone marrow. T lymphocyte cells include cytotoxic Ts, which destroy virus-infected cells such as tumor cells, and helper Ts, which stimulate B cells and activate cytotoxic Ts, as well as suppressor Ts, which moderate the immune response by inhibiting B and T cells, and then memory Ts, which are reactivated only by re-exposure to a previous antigen. T lymphocytes form in the thymus, and they develop from fetal liver stem cells, which migrate to the thymus gland during development. There are several types of Ts, and they can be divided by function. T cells are the major component of cell-mediated immunity. What do? Well, they guard against viral and fungal attacks. They mediate graft rejection. They destroy tumor cells, and they suppress antibody-mediated responses to infection. So, if we look at each of these T cell roles, they're all very important. You might wonder about the suppressor T. What good is the suppressor T? It only turns off the immune response. Well, the idea here is that the immunological process doesn't run out of control and end up wasting cellular resources fighting a pathogen that's already been defeated. So you need to have some way of turning off the immune response once it's been initiated and once the pathogen's been destroyed, or else eventually it's going to work against your body's overall health. So with that said, let's take a little bit deeper look at T cells.
There are a number of types of T cells involved in specific immunity. T cells recognize their specific foreign protein or antigen only when it is presented on the surface of a body cell. One type of T cell is the cytotoxic or killer T cell. Its role is to destroy infected or cancerous body cells. In this case, a pathogen enters the cell on the left, and that cell moves foreign protein to its surface. A patrolling killer T cell recognizes and binds to that protein and releases perforin, a protein that ruptures the membrane of the infected cell. A second type of T cell is the helper T cell. One of the roles of a helper T cell is to activate B cells. At the top of the screen, a phagocytic white blood cell is presenting antigen from a pathogen it has engulfed. The B cell that responds has antibodies for the same antigen that activates the helper T cell. The T cell sends out chemical signals that affect various immune cells. These chemicals stimulate the B cell to divide and produce a clone of antibody-releasing cells.
Okay, let's talk about B lymphocytes for a bit. What makes up their population? Memory Bs are reactivated only by re-exposure to a previous antigen, while plasma cells actively secrete antibody that attaches to antigen and marks them for destruction. B cells are immunoglobulins that provide the ability to recognize foreign organisms, stimulating the antigen-antibody reaction. So they protect us against bacterial and viral infections and reinfection, and they're stimulated by antigen to form a clone of cells that respond specifically to that antigen. And these are memory B cells that can get stored during the course of infection to provide a much more vigorous immune response the second time that particular pathogen manages to make it through our nonspecific defenses and inside our body's tissues. Note that we go through great pains to select only those cells specifically designed to fight the pathogen of choice, and we don't waste our time causing all of the lymphocytes to divide in response to a particular infection. So we don't waste our resources and waste our time. Immunoglobulins come in several flavors. IgG make up about, let's call it 80% of total immunoglobulins, while IgA is about 10% and IgMs about 8%, IgDs about 0.2%, and IgEs about 0.5%. B cells are coated with this particular type of immunoglobulin, and this provides the recognition that the B cell needs with the foreign antigen in combination with the MHC protein in order to properly function when the pathogens manage to make it through the nonspecific defenses. They stimulate the antigen-antibody reaction, and they bind to the pathogen and stimulate the phagocyte to engulf it. B cells are coated with immunoglobulins that give them the ability to recognize foreign proteins that stimulate an antigen-antibody reaction. The immunoglobulins are usually all present during an immune response, but in varying amounts depending on the specific antigen involved in the overall health of the person. How does the antigen-antibody complex inactivate the pathogen or the toxin? By binding to the toxin and stimulating phagocytes to engulf the whole thing. So essentially, you immobilize the pathogen and you send out chemical signals telling the immune system, here is the pathogen, come get it, destroy it, and then hopefully that gets rid of that particular pathogenic situation. Okay, complement is an extremely interesting set of chemical cascades that help the humoral immunity to properly function. They also help cell-mediated immunity. Complement fixation leads to enhanced destruction of pathogens. Activation of normally inactive proteins, which is found in the plasma or body fluids, is a hallmark of complement fixation. Pathogens are then destroyed by lysis of the cell membrane or by phagocytosis. So it's a protective mechanism initiated by the antigen-antibody reaction, and it's activated by immune reactions mediated by IgG and IgM. So let's take a little bit closer look at how complement works.
Regardless of whether the complement system is activated by the classical, alternative, or lectin pathway, the activated complement proteins are involved in several important processes associated with host defenses, including inflammation, attraction of neutrophils, opsonization, and cell lysis. Complement C3A participates in inflammation by inducing changes that cause the walls of local blood vessels to become more permeable. This facilitates movement of phagocytic cells from the circulation into the tissues. Complement 5A induces a directed chemotactic migration of phagocytes to the site of complement activation. Complement C3B functions as an opsonin. It binds to microbial cells, making them more susceptible to phagocytosis. Complement proteins C5b, C6, C7, C8, and C9 react together to form a hole in the cell membrane. When C5 convertase converts C5 into C5a and C5b, the C5b binds to the cell surface and combines with C6. C5b6 binds C7, enabling it to insert into the membrane. Binding of C8 is followed by binding of several C9s. The hole generated by formation of this membrane attack complex causes the cell to lyse.
So what happens when the immune system starts to decline in function, either as a result of age or of disease state? It's characterized by an increased susceptibility to bacterial infections resulting from a B cell deficiency, and increased susceptibility to viral, fungal, and protozoan infections, usually from T cell deficiency. An immunodeficiency disease results in an individual who does not have the capability to rid themselves of a foreign body or harmful substance. The severity can range from minor chronic infections to fatal conditions. Some immunodeficiencies are genetic and present at birth, while others don't appear until much later. Still others have acquired aspects to them, such as AIDS. Destruction of helper Ts leaves the person vulnerable to infection as well as malignancy, that is, cancer. AIDS is caused by the human immunodeficiency virus, HIV. It is diagnosed by the presence of HIV antibodies in the blood. A common test used is the ELISA, stands for enzyme-linked immunoabsorbant assay. A confirmation can also be done with a Western blot, in which proteins from the affected individual are separated on a polyacrylamide gel according to size. Those protein products are then transferred to a special type of paper called nitrocellulose, and then they're probed with an antibody against the particular protein species that you're looking for, in this case the presence of HIV antigen. It reduces cell-mediated immunity, and it attacks the nervous system directly. After the initial infection, blood tests may be negative and because of insufficient antibody production. As the infection progresses, the patient is monitored by a periodic measurement of the number of T cells, so they constantly are doing a T count, and also the amount of viral load present in the blood. Many of the complications of AIDS are due to opportunistic infections that attack the individual with a weakened immune system. Some of the treatments include prophylaxis against some of the common agents, as well as antiviral agents, which are given in combination to reduce the circulating active virus load. Medications may prolong or improve the quality of life, but there is no current effective cure for AIDS, only a management or a treatment of the symptoms. So let's take a little bit deeper look at AIDS.
AIDS is the final stage of human immunodeficiency virus, HIV, disease. The virus attacks the immune system and leaves the body vulnerable to a variety of life-threatening illnesses. Common bacteria, yeast, parasites, and viruses that ordinarily do not cause serious disease can cause serious or fatal illnesses in those with AIDS. The Centers for Disease Control, CDC, and Prevention defines AIDS as beginning when a person with HIV infection has a CD4 cell, also called T cell, count below 200. AIDS is also defined by the opportunistic infections and cancers that occur in someone with HIV infection. AIDS is the 5th leading cause of death among persons between ages 25 and 44 in the United States. More than 47 million people worldwide have been infected with HIV since the start of the epidemic.
We now know that HIV is not transmitted through casual contact, but rather through the exchange of certain bodily fluids: blood, semen, vaginal secretions, and in some cases breast milk transmitted from infected mothers to their nursing infants. Exchange of such fluids is most likely to occur during unprotected intercourse or through multiple use of injectable needles.
Those at highest risk for HIV infection include homosexual or bisexual men engaging in unprotected sex, intravenous drug users who share needles, the sexual partners of those who participate in high-risk activities, infants born to mothers with HIV, and people who received blood transfusions between 1977 and 1985. There is no cure for AIDS, but several treatments can delay the progression of disease and improve quality of life. Antiviral therapies suppress the replication of the HIV virus. The newest treatments involve a combination of several antiretroviral agents, called highly active antiretroviral therapy, or HAART. It has been highly effective in reducing the number of HIV particles in the bloodstream. This can help the immune system recover and improve T cell counts.
Okay. HIV transmission at present is through direct contact with blood or semen of the infected person. As we've touched on already, sexual contact, blood transfusions and other blood products, and contaminated shared needles, such as is seen in illicit IV drug use, are just a few of the modes of transmission. Also, accidental needle sticks in a clinical venue, and you can also transmit it to the fetus through the placenta during the birth process of the infected mother. And the reason for this is that the virus is very small and as a result can cross the placental barrier. Sexual contact remains the most common mode of transmission of this disease. Homosexual as well as heterosexual populations are both at risk with unprotected sex. Does casual contact with an infected person, such as hugging, handshaking, or touching, transmit HIV? And the answer is no at present. And the reason that we put the qualifier at present in there is that we have to remind ourselves when we're talking about bacteria or viruses, any living pathogen, or in this case of the virus, something that is considered on the edge of life, but it has genetic material, is capable of mutation, and mutation can change the characteristics of a pathogen in just a very short generation time. So we put the qualifier at present in front of all these warnings about transmissible diseases. Okay, how do we treat AIDS? HAART, as the video indicated, is one approach. There are several drug combinations that can be used, with 20 approved by the FDA for current use. You can find different sets of cocktails at the website given below. There's more than one formulation that's currently in use to treat individuals with AIDS. However, the downside of this cocktail is that there's drug toxicity and side effects. You can get reduced immune function, rash, and hepatotoxicity, and kill the liver as a result of some of these regimens. There are also prophylactic antibiotics that need to be administered to prevent infection from reduced immune function. And again, there's currently no cure, but there is a way to manage the disease so that it becomes a chronic condition and not an instant death sentence. Common side effects associated with AIDS treatment are, as we've noted, and we want to keep in mind that there are a variety of cocktails that can be used for HAART. Most of them involve a combination of nucleotide analogs such as AZT and protease inhibitors, which the virus employs in order to assemble the virus capsule around its genetic material. And so the idea is that if you hit it in two places at once, this is a more effective mode of attack than using one biochemical approach. And it's been largely successful at reducing the mortality rate associated with AIDS and also extending the lifespan. Okay, we need to take universal precautions when we're talking about dealing with individuals who have immunodeficiency diseases, in this case AIDS. What are these precautions? Thorough and frequent hand washing. PPE worn as required by the specific tasks, such as gloves, gown, goggles, and masks. And proper disposal of sharps in designated biohazard containers. No needle recap prior to disposal to avoid the risk of needle sticks. And we also want to take caution in the handling of lab specimens. Proper containment and disinfection of blood and body fluid spills is also paramount to halting the spread of the disease. And we want to use clean mouthpieces for resuscitation bags. And to this end, most components of hospital equipment anymore that come into contact with the patient tend to be disposable, and that's one of the ways that we cut down on the risk of infection and spreading the disease in a clinical environment. And when a disease spreads in a clinical environment, it's called a nosocomial infection. So the reason that these are a greater risk to individuals who find themselves hospitalized or in a critical care facility is because you have a higher density of people that carry disease in a smaller physical space, and the risk of infection goes up whenever you have that sort of situation. So for infection control purposes and prompt treatment, any accidental needle sticks needs to be reported ASAP to the proper regulating body. Needles should not be recapped or broken prior to disposal to avoid the risk of needle sticks. And disposable linen should be placed in appropriate containers. Non-disposable items should be properly decontaminated and disinfected. Healthcare workers should be also protected against Hep B with a vaccination series. And again, remember that what vaccines do for you is they prep the immune system for the possibility of infection, so that when an actual pathogen shows up with that same antigen, the immune system can deal with it in a relatively efficient fashion. Okay, common variable immunodeficiency is another type of immunodeficiency disease. This is an acquired B cell deficiency where we have an absence of antibody production or function, and it usually results from the immune system becoming dysregulated, and this leads to a failure of B cell differentiation. So essentially you've got a bunch of immature B cells flooding the system, incapable of fighting disease. Selective immunoglobulin A deficiency is the most common form of immunodeficiency. This is resulting from inadequate production of IgA, and it's caused by an autosomal dominant or recessive allele. The gene in question is called IgAD1 or 2, and these are major histocompatibility protein genes, and remember that the MHC genes are involved in presenting foreign antigen on the surface of antigen-presenting cells, and in that way the immune system becomes alerted to the presence of a disease-causing entity. And so if you've got defective MHCs, what happens is that you're incapable of triggering that immune component, and as a result you leave yourself open for opportunistic infection. Severe combined immunodeficiency, or SCIDS, is a pretty significant blow to the immune system. It's basically an inherited lack of T and B cells. There are two forms. There's an X-linked recessive, which is the result of a cytokine receptor mutation, and an autosomal recessive that's a result of a recombinase or tyrosine kinase mutation. And you might wonder, well, what are those? Okay, well, let's revisit the inheritance first. X-linked recessive means that the gene lies on the X chromosome and is therefore referred to as sex-linked. These traits are more common in males than in females because males only have one X chromosome while females have two. So in order for a recessive trait to show in males, only one copy of the gene is necessary, whereas in females the individual would need two copies of the defective allele, one on each X chromosome. Now, it's recessive because you need two bad copies of the gene in order for the trait to be exhibited. A cytokine receptor is basically a cell surface protein that responds to cytokines, which are chemicals that are secreted by cells that cause other cells to divide. There's also an autosomal recessive version of this disease. This again would be a trait that in order for it to be expressed has to have two bad copies in both males and females, because in this case we're talking about autosomes, and regardless of your sex, the number of autosomes you possess is identical. So you need to have one bad copy on each chromosome that contains that particular locus in order for the disease to show up. And in this case, the error is in the recombinase or the tyrosine kinase gene. Now, recombinase is an enzyme that's involved in generating antibody diversity during the formation of the immune system. And so if you have a lack of recombinase or a lack of recombinase activity, what's going to happen is you're going to develop an immune system that's not very diverse, and as a result won't protect the individual against a sufficient number of pathogenic organisms. Tyrosine kinase is a little bit of a different entity. It's involved in intracellular signaling, and it's found primarily in the cytoplasm of cells, and is a method by which signals that bind to receptors on the cell surface are transmitted to the cell nucleus in order to trigger the turning on of specific genes evoked by that signal. And if you have a problem with certain tyrosine kinases, those signals are not going to be sent to the nucleus, and the result may very well be a lack of differentiation, in this case of the T and B cells. So that's where those particular proteins act. This group of immunodeficiency diseases includes these examples and many others. Some are quite rare in the general population, but they may be genetic, and so may occur more frequently with an extended family or a demographically isolated population. Basically, this would be seen in populations that exhibit founder effect, where a group of individuals basically stays in the same geographic location throughout their history, and as a result, certain genes are overrepresented, and it would be those genes that were carried by the original founders of that population. That's where the term founder effect comes from. The symptoms of these diseases vary widely from relatively asymptomatic with some forms of IgA deficiency to severe and fatal. CVID is characterized by pneumonia, bronchitis, sinusitis, and otitis media. You also see lymphadenopathy, splenomegaly, hepatomegaly, autoimmunity, and opportunistic viral and bacterial infections. Let's revisit what each of these are. Pneumonia, basically liquid in the lungs, bronchitis, and irritation of the upper respiratory tract, sinusitis, an irritation of the sinuses. Otitis media is basically a middle ear infection. Lymphadenopathy, swollen and painful lymph nodes. Splenomegaly, an enlarged spleen. Hepatomegaly, an enlarged liver. Autoimmunity is where the immune system actually turns and attacks your own tissues, and we'll get more into that in the next segment, as well as opportunistic viral and bacterial infections, and those are infections that occur in individuals that have a compromised immune system. They're unable to fight pathogens that ordinarily wouldn't produce a significant amount of disease. SCIAD is often asymptomatic, but it can be characterized by recurrent sinopulmonary and gastrointestinal infections, as well as concurrent autoimmune disease and food allergies. And SCIDS is basically a gut punch to the immune system. You see recurrent infections with bacteria, viruses, fungi, and protozoa, as well as chronic diarrhea and failure to thrive, meaning you don't grow and often you don't live. Pneumocystic pneumonia and mucocutaneous candidiasis are also seen, again because of the lack of immune function. There's a little lymphatic tissue present, and these individuals, in order to live any significant number of years, have to exist in a sterile environment, and that's something that's very difficult to do. This would be the classic boy in the plastic bubble scenario. Okay, next block is on autoimmune disease. Lymphocytes and antibodies can become sensitized to develop against the body's own organs or tissues. This can be triggered by disease, injury, metabolic change, or mutation in immunologically competent cells. It may be caused by certain drugs or chemicals, as well as trauma or viral infection. These diseases are believed to be acquired rather than genetic. Identified genetic markers do predispose some people to these diseases. They can affect any system of the body, such as the musculoskeletal, renal, or the neurologic. Certain drugs or chemicals, as well as trauma or viral infection, can also alter specific body proteins enough to be recognized as foreign proteins by the immune system. Essentially, there's three major ways that you can generate an autoimmune disorder. You can change the surface antigens on the body's tissues, usually through mutation. You can change the recognition proteins on the surfaces of the white blood cells and lymphocytes, and as a result cause them to recognize as foreign something that wasn't initially recognized as foreign. But the most common mode is exposure to a cross-reacting antigen, where as a result of a viral or bacterial infection, just as an example, you bring in an antigen that is similar enough to your body's own antigens that your immune system selects a white blood cell, a lymphocyte, that will very specifically recognize this similar antigen, and once the pathogen's been removed, those white blood cells and those antibodies, since they're at such high concentration, will now recognize your body's own antigens as alien, even if the recognition isn't 100%, even if it's a small percentage. If you have a large number of white cells or antibodies that are capable of binding, that effectively is the same thing as binding the antigen all the time. And the result then is attack of your own tissue, leading to tissue necrosis and tissue death. And so this is a dangerous situation to be in. Pernicious anemia is characterized by an impaired absorption of B12 and B12 deficiency due to decreased gastric production of hydrochloric acid and a shortage of intrinsic factor. The treatment consists of monthly intramuscular injections of B12 for the person's entire life. B12 is very important in the formation of healthy, hearty, and happy lymphocytes, a competent B cell and T cell population. And so if you lack this, you're going to lack the ability to generate proper leukocytes. It's also necessary for red blood cell formation and DNA synthesis. So a deficiency causes problems in red blood cell development and function. Diagnosis is confirmed with the Schilling test, which is a radiolabeled B12 tracer, as well as other clinical findings. Red blood cells and platelets are enlarged and malformed, and blood replacement may be needed in severe cases. A balanced diet high in vitamin B12 can also help. Okay, pernicious anemia is characterized by weakness and tingling and the numbness in the extremities, altered vision, lightheadedness, tinnitus, ringing in the ears, palpitations, weight loss, digestive disturbances, and sore tongue. The signs are decreased red count as well as white count. Platelet counts are also down. Increased red blood cell mean volume, so you get fewer red blood cells, but the ones you have are larger in volume. Decreased hemoglobin levels, jaundice as a result of hemoglobin breakdown, optic nerve atrophy, and decreased amount of gastric acid. Changes in the central nervous system can lead to neuritis, paresthesia, weakness, headaches, irritability, and depression. Connective tissue diseases are a class of diseases in which the immune system attacks components of the connective tissue extracellular matrix. Collagen accounts for 30% of the body's protein, and in systemic lupus, what happens is that your immune system turns around and attacks all of your body's connective tissue, and we'll get into a little bit more detail about that in a moment. Other autoimmune diseases include systemic scleroderma, which is a hardening and shrinking of the skin, Sjögren's syndrome, rheumatoid arthritis, juvenile RA, ankylosing spondylitis, polymyositis, and there's no cures for any of these particular conditions. Many autoimmune disorders affect collagen, which is the main component of connective tissue, and it's essential to all body structures. This accounts for, again, 30% of the body's total protein. There are no cures for these diseases. The goal for treatment is to inhibit the overactive immune system from attacking the connective tissue. And that's really the best outcome that we can hope for, because we can't go back and generate a new immune system. So once this goes off the rails, it's pretty much a lifelong struggle. Okay, let's touch on our first major autoimmune disease. This is systemic lupus erythematosus, abbreviated SLE. It's characterized by inflammation of the skins, the joints, the nervous system, the kidneys, the lungs, and other organs. You may also see a butterfly rash across the face, as indicated here. Other rashes may appear on other exposed skin areas. Lupus may develop slowly over many years or acutely with fever, joint pain, and fatigue. It occurs most often in women in their 30s and 40s. The cause is unknown, so we say that it's often idiopathic, but there seems to be a genetic predisposition to it. Precipitating events may be stress, pregnancy, overexposure to UV light, or immunizations. So, butterfly face rash, alopecia. This is hair loss. Photosensitivity, meaning you're sensitive to light. Raynaud's phenomenon, which is a vasospastic disorder causing discoloration of the digits, and that was the other panel on the previous slide where you could see the discoloration in the fingers of the affected patient. Thrombocytopenia, meaning a lack of platelets. Discoid skin lesions, nasopharyngeal ulceration, and polyarthritis, along with pleuritis or pericarditis. Pleuritis, again, inflammation of the pleural membrane, and pericarditis, inflammation of the pericardium. Also protein in the, or red blood cell cast in the urine, so proteinuria or hematuria are also hallmarks of this disease, as is hemolytic anemia, basically a loss of red blood cells due to the fact that they lyse. False positive serology can also result, and this is linked primarily to abnormal numbers of antibody in the blood that will nonspecifically bind in the ELISA test. Also, abnormal blood antibodies can be produced. These would be antibodies that are reactive to your body's own tissues, and leukocyte cells may be present in the lab test. The diagnosis can be made if 4 or more of these symptoms or positive lab tests are present either at the same time or sequentially. On what is a diagnosis of SLE based, and it's the presence of 4 or more of these symptoms. Anti-inflammatory drugs are used to treat this disease, and these may range from aspirin therapy to corticosteroids. Immunosuppressive drugs are used when and if the condition becomes life-threatening. And again, you walk a very fine line with all of these diseases when you use anti-inflammatories and immunosuppressants, because while you abate the symptoms of the disease, very often you expose the patient to the possibility of opportunistic infection due to suppression of the immune system. So this is a very fine line to walk as a clinician. Rheumatoid arthritis is characterized by chronic inflammation and edema of the synovial membranes and the surrounding joints. So basically the tissue that makes up the joint capsule can become inflamed. Here you can see an individual with rheumatoid arthritis in the digits. Also results in destruction of cartilage and adjacent bone. It can produce weight loss, fever, and malaise, which is essentially a loss of energy. You'll also experience joint pain and stiffness, usually in the AM, and also bilateral joint tenderness, edema, erythema, and warmth. Bilateral joint tenderness meaning you experience it on either side of the body. Edema, remember, is swelling. Erythema is redness. And warmth would be, again, a result of the inflammatory response, which normally is designed to protect us against pathogens, but in this case is producing a disease state. Rheumatoid arthritis can affect only 1 or 2 joints, but more commonly affects many. It can cause more generalized inflammation that affects blood vessels, cardiac muscle, skin layers, and tissue surrounding the lungs. It can appear suddenly without warning, or very slowly with recurrent progressive attacks. And again, this is another one of those idiopathic diseases. It occurs, and there are described phenomena that we associate with the onset of this disease, but in order to conclusively pin the cause to a particular event, a lot more clinical advancements are necessary in the field of rheumatology. Okay, rheumatoid arthritis treatment is aimed at reducing the inflammation and pain, preserving joint function, and preventing joint deformities. Anti-inflammatory meds are the first choice for treatment. These include aspirin and NSAIDs, which stands for non-steroidal anti-inflammatory drugs, and even corticosteroids if the symptoms are severe. Disease-modifying antirheumatics include gold compounds and penicillamine, as well as new biologic response modifiers. Special splints or devices may be used to improve quality of life and allow greater independence. Prognosis is best with early medical intervention. Okay, ankylosing spondylitis is an inflammation and ossification of the joints leading to decreased range of motion and spinal bone fusion. It can be caused by a mutation in the HLA-B27 antigen, which is expressed in joint tissue. Sacroiliac spinal area is usually affected first and results in recurring low back pain and morning stiffness. A history may include inflammatory bowel disease called IBD, heel pain, and family incidence of arthritic conditions. Obviously, there's a genetic component to this particular condition. The characteristic posture is a forward spine flexion resulting from fusion of the spinal vertebrae, and the disease progression is usually slow, perhaps over the course of 20 years or greater. Treatment with anti-inflammatory agents can relieve pain and swelling, and physical therapy and exercise to maintain mobility are very important. And here you can see a slide showing the progression. So here we see a normal spine, and then here we see the onset of inflammation, where we have ligaments and joints exhibiting aspects of the inflammatory process. This is followed by bone protuberances, so this is the beginning of ossification and formation of syndesmophytes, which are opportunistic syndesmoses, synarthrotic joints. And then finally we get to spinal fusion, where you have an actual fused disc. And as a result, mobility is extremely limited. So here you see literally the transformation of an amphiarthrotic joint into a synarthrotic joint as the result of a disease process. Okay, multiple sclerosis is an inflammatory disease of the central nervous system resulting in demyelination of nerves that occurs in the brain and the spinal cord. The signs and symptoms are primarily neurological and related to areas of myelin destruction. There's no cure, but exacerbations are treated with corticosteroids or immunosuppressive agents. It affects women more commonly than men, and again, when we think about myelin, we have to remember that its primary role in the nervous system is to serve as an electrical insulator so that signals that move from the central nervous system to the peripheral nervous system to the effectors don't diffuse out and not make it to their intended target. And when you destroy the myelin, what happens is you destroy that insulation and you reduce the integrity of the signal. And again, this is another one of those diseases. It's idiopathic. We don't really know the ultimate cause, and we have no cure. Okay, myasthenia gravis is a chronic progressive neuromuscular disorder in which autoantibodies are generated to the acetylcholine receptor in muscle cells. So this blocks the transmission of the signal across the neuromuscular junction and can result in progressive paralysis. Ineffective nerve muscle junctions result in severe weakness, generally appearing first in the face, difficulty talking and swallowing, drooping eyelids, and diplopia. And eventually, if it progresses, it can result in complete paralysis of the affected neuromuscular junctions. The cause of myasthenia gravis, again, is idiopathic, but most patients have a thymus dysplasia, hyperplasia, or tumor associated with this disease. Thymectomy is usually indicated in these circumstances. And what is the standard treatment for patients with myasthenia gravis? Usually acetylcholinesterase drugs and corticosteroids. And the idea here is that when you've got a problem sending the acetylcholine signal to the downstream effector, the muscle, what you want to do is dilate the amount of time the acetylcholine spends in the neuromuscular junction so that it at least has some chance to bind to the receptor, perhaps by knocking the antibody off of its binding site due to a better binding interaction, basically a competition for that receptor on the muscular side of the neuromuscular junction. Sometimes this is effective and sometimes it's not. Okay, vasculitis is an inflammation of the walls of the blood vessels that can lead to necrosis, thrombus formation, and local infarction. It can be classified as small vessel or systemic, and it can affect medium and large arteries. The treatment of vasculitis usually includes corticosteroid therapy to decrease generalized inflammatory symptoms. Analgesics may also be given for additional relief, and immunosuppressive drugs may be indicated for more severe situations. Okay, that closes out our video podcast for July 4th. I'm going to send this package as a Pando file to your email along with an application designed to play this particular lecture. In the event that you have trouble downloading and viewing this particular lecture, I will also post it on YouTube as a private video, and I will give you instructions on how to access this particular lecture. Thank you very much, and I'll see everybody next week. Oh, and remember to complete the emailed take-home test and vocabulary quiz, and to take advantage of the lecture notes. Thank you for joining.